good afternoon to everyone. So today with my guest, Spencer Keene from the University of Birmingham and Maastricht University, and Caroline from Cegedim team, I'm very pleased to welcome you to open this session dedicated to SIN, the Cegedim real-world data. And with Spencer, we will try to answer the following question: can research using real-world data lead to improve patient management? So please feel free to ask questions during the presentation using the Q&A section located in the lower part of your screen. And we will reserve time at the end of the webinar to answer some questions. Okay. So after a short introduction to tell you a few words about us and the SIN real-world data, I will hand over to Caroline, who will give you some European figures on COPD. Then Spencer will present a case study, and finally, Caroline and I will take over to see how we can draw conclusions for other diseases. Okay. So the first question about us, who we are. Cegedim Health Data is a global entity and a trusted partner for real-world data and real-world evidence. As you know, the pressure to use real-world data is more and more important, and COVID-19 was a real catalyst for acceleration. Our team worked with the pharmaceutical industry, but also consulting firms and researchers, and were referenced by healthcare authorities in the UK with the NHS and in France with HAS and ANSM. We collect anonymized data through thousands of touchpoints and build a unique longitudinal medical database. This is SIN, a Cegedim proprietary medical database containing patient characteristics and clinical outcomes. SIN contains millions of anonymized patient electronic medical records covering over 25 years of historical data. Very important, the access is immediate with no protocol, whatever the purpose of use is: commercial, medical, market access, or R&D, or in other words, across the pharma value chain. So let me give you just a few numbers about our European coverage. SIN is a European network of GP and specialists, and this is more than 68 million anonymous patients covering primary and secondary care in 5 countries, with France, the UK, Spain, Belgium, and Romania. And this year, Germany and Italy will join SIN database. SIN is also more than 1,600 publications, and most of which can be consulted on our website. I can just advise you to go and see. I will now hand over to Caroline, who will present some figures on COPD.
Thank you, Gilles. Hello, everyone. Good morning, good afternoon. So I will now present you some key data on COPD. COPD represents worldwide 251 million cases. On this map, you can see an overview of the global prevalence of COPD, which is 30.1%. Low and middle income countries are a lot impacted by COPD. COPD is a major cause of chronic morbidity and mortality. Per year, it causes 3.17 million deaths. This is now one of the top 3 causes of death. COPD represents an important public health challenge that is both preventable and treatable. Globally, the COPD burden is projected to increase in coming decades because of continued exposure to COPD risk factors and aging of the population. Now, we are going to focus on Europe. So we think we can collect a large number of patients suffering from COPD in all available countries, as you can see on the table on the top left of the slide. From more than 60,000 patients over 1 year in France to almost 50,000 patients in Romania, with more or less in the UK, in Belgium, and in Spain. On average, those patients are 69 years old, and we can observe a majority of men. If we look deeper in the treatment received by these patients, we can observe that 43% of them are on dual therapy and 41% of them are on triple therapy and more. If we consider now the products of maintenance therapy market, ICS, LABA, LAMA, and all the fixed combinations, one of the main brands prescribed in all countries is Spiriva. Then among the fixed combinations, formoterol budesonide and indecaterol glycopyrronium are among the main treatments given. In the UK, we can note that the fixed triple therapy trilogy is also belonging to the main treatment prescribed in 2020. However, this list of treatment is not exhaustive at all, as we are only on the top 4 or 5. There are lots of molecules and possibilities for COPD patients. In order to manage patients the best and to provide them the most appropriate treatment, we'll see the next part, how real-world data can lead to improved patient management in COPD. I hand over now to Spencer.
Hi, my name is Spencer Keene, and I'll discuss a couple projects from my PhD with University of Birmingham and Maastricht University. Okay, so first we want to ask the question, can research using real-world data lead to improved patient management? And the short answer is yes, it can. But first, let me just define what real-world data is. So it's data relating to patient health status and or delivery of healthcare routinely collected from a variety of sources. And regulatory decisions based on real-world data are expected to increase. But real-world data is much more than just about drug performance. It's also looking at other aspects, and we'll discuss these using COPD as an example. So why did I use THIN? So THIN provides a good breadth of coverage across the UK and other countries if you choose to use those data. There's good size. The analyses are going to be well powered. So if you're looking at rare events, then that's a good thing. There's potential for long-term follow-up, which especially when compared to something like RCT data or secondary use of RCT data, it's representative of the wider population, both in terms of the prevalence of certain diseases as well as baseline characteristics. And the data quality is ensured with the quality and outcomes framework, which rewards practices for a good recording and measurement within patients. And so some common COPD variables that I used in my analyses, such as age, obstruction, BMI, breathlessness, which is measured with the MRC score, smoking behavior, and things like that. So we'll discuss those more. So what is COPD? So it's a common preventable and treatable disease characterized by persistent respiratory symptoms and airflow limitation. And the airflow limitation is caused by emphysema, which is characterized by destruction of the alveoli and or narrowing of the airways caused by inflammation. And that's typically described as chronic bronchitis. And so patients can have either emphysema, chronic bronchitis, or some combination of the two. And so these are the mortality rates for chronic respiratory diseases as a whole, from region to region, and in males on the left and females on the right. And we see that males tend to have a higher mortality rate than females across all regions. And people in South Asia have the highest mortality rate, whereas people in Africa have the lowest. And COPD tends to actually contribute the most to the overall mortality rate for chronic respiratory diseases, and that's shown in green, and asthma is in red. So the GOLD group was established in 2001 to raise awareness of COPD and improve prevention and treatment of COPD. And initially, guidelines focused on FEV1 over time. I'm sorry, FEV1 alone in order to basically diagnose patients and also assess their severity of COPD using FEV1 severity groups at various thresholds. And then patients were treated based on their which category of severity group that they were placed in. But now, mainly since 2011, we've actually treated patients based on their symptoms and health-related quality of life and exacerbations, which are kind of like symptom flare-ups of COPD. And so now it's more so that FEV1 is necessary, but it's really insufficient to account for all the complexity and heterogeneity that we see in COPD. And so the first part of this talk will be some research that I did for my PhD, and part one will be talking about the stability of the ADU score in COPD patients from thin. And so, yeah, like I just mentioned, COPD is heterogeneous, so there's multiple factors that affect COPD, and also the multiple factors can affect each patient, and each of those factors have a varying proportion within across patients. And so multi-component prognostic scores can combine multiple components into one overall score that can be used to predict adverse outcomes. And the ADU score is one of these prognostic scores that are used in COPD, and it actually combines age, dyspnea, and airflow obstruction. And it's been shown to be the most accurate prognostic score in a somewhat recent network meta-analysis that looked at 9 other scores. And so if at one time point we look at multiple components outside of FEV1, then maybe at multiple time points over a span of some follow-up period, maybe we should also look at multiple components beyond just FEV1. And so this is kind of an older figure from 1977 that looked at, it's basically showing the rate of decline in FEV1 over time, and those who smoke is actually greater than those who never smoked. And if you stop smoking, then that your rate of decline actually improves. But a lot of patients actually have stable FEV1 and actually have worsening respiratory symptoms. So I guess the question is, are these people also progressing despite having stable FEV1? And that's sort of the why we performed this study. And so we wanted to ask the question, is it best to measure the ADU score serially? And so some of the things we wanted to look at were how much does the ADU score change over time, and is this change predictive of survival, and are there factors that are associated with a worsening ADU score? And so some reasons again why we wanted to do this was maybe updating the mortality predictions can support management changes in action plans and maybe we can communicate to the patient that their risk is changing. And so far, it's relatively sparse in terms of previous studies that have done this, and that's especially in primary care. So some of the methods, we started with around 67,000 patients diagnosed with COPD, and they're identified from 2005 to 2014. We calculated ADU scores annually using the most recent measurement of each component within a year, and then we combined those components for that year. And then patients had to have at least 3 ADU measurements in separate years, like I said, and they had to be diagnosed after the age of 40. And we used multivariate COTS regression to estimate the effect of serial ADU scores on mortality after adjusting for the baseline ADU score. And then we looked at the effect of baseline characteristics on these ADU score trajectories using linear mixed effect models. And so some baseline characteristics is mostly male, around 69 years of age on average. FEV 1% predicted was about 60. BMI was around 27, and quite a few had asthma, about 36%, and also ischemic heart disease, around 20%. And so we found that the baseline ADU score on average was around a 7.4, and that the range is actually from 0 to 14, and we had patients across the full range. The ADU score increased by about 0.19 points per year. And you can see on the left that the distribution is approximately normal when looking at the average ADU score change per year. And around 7% had an increase of at least 1 point in the ADU score per year. And so what we found was that per 1 unit increase in the ADU score per year, there was actually a 2-fold increase in the mortality rate. And that was actually after adjusting for the baseline ADU score and baseline of the actual components of the ADU score, and also other factors such as sex, BMI, smoking. And so our conclusion was that additional ADU score measurements might actually be beneficial above and beyond the initial ADU score. And also we found a similar finding with the last ADU measurement adjusted for the baseline ADU measurement. And so here we're looking at characteristics associated with worsening ADU scores, and we found that people who were depressed actually had worsening ADU scores when compared to those who were not. And those who were underweight had tended to have worsening ADU scores, although that wasn't really statistically significant. And that's compared to those who were normal with normal BMI. And those who were overweight and obese actually had better or a decreased rate of worsening in the ADU scores when compared to those who are normal weight. And then also we found that current smokers especially had a worsening ADU scores when compared to never smokers. And so some limitations of the study. So the linearity assumption we assumed that the ADU scores changed in a linear fashion over time, even though some patients may have increasing or decreasing ADU scores. There's some unmeasured confounding, which is what you might expect. And so far, unfortunately, the ADU score and really a lot of other prognostic scores are underutilized in COPD. But until some impact studies are performed to actually show that these prognostic scores have an effect on decision making, but then also subsequently patient outcomes, then the results of the study don't really have a lot of clinical impact, at least not yet. But hopefully that will change once prognostic scores are actually used more often. And so some strengths are that we included primary care patients, and COPD is mainly managed in primary care. We had a larger sample than a lot of previous studies that looked at serial BODE scores in secondary care and tertiary care populations. The ADU scores were modeled using a mixed effects regression, which accounted for any missing ADU scores and also adjusted for correlation between ADU scores within patients. And so our conclusions are that, as we know, one-time use of the ADU score might be helpful for defining treatment options and communicating risk to the patient. However, a serial assessment may identify patients with worsening disease and also update their prognosis over time. And this may be especially true for those who smoke, who are depressed, and those with low BMI, since their ADU scores tended to worsen at a greater rate than other patients. Okay, so then for part two, this is a separate study, but it's somewhat related, looking at smoking status, looking at the effect of smoking status and COPD on BMI trajectories using thin. And so, as I just mentioned, smoking and low BMI seem to be associated with worsening ADU scores. But these two factors are related. So it's been found that in general population, people who smoke tend to lose weight, and then quitting tends to result in gaining that weight back. However, in COPD, it's generally considered that low BMI is a feature of COPD, and not smoking, despite the fact that many COPD patients remain smokers after diagnosis. And also, low BMI is an independent risk factor for mortality. And we know this from prognostic scores that have shown that low BMI independently is an independent risk factor for mortality and contributes to more accurate predictions. And also the obesity paradox, which again showed that low BMI is associated with mortality after adjusting for confounders, despite the fact that that may not be what you'd expect in the general population. But yeah, so it's still unclear whether or not BMI is due to COPD or smoking. And the best study that's been done on this so far is probably the one by Van den Borst, published in 2011, that looked at non-COPD controls, and they looked at various smoking groups within these controls, and also people diagnosed with obstructive lung disease. And they ended up finding that former smokers had highest BMI, followed by never smokers. And then that smoking controls had similar weights compared to those with obstructive lung disease, and that all the trajectories were somewhat similar across these four groups, but they didn't end up looking at smoking within the patients with obstructive lung disease because of inadequate power. So we ended up doing this. So we ended up having more groups. And so one of the questions we wanted to answer is, does smoking or COPD primarily influence BMI trajectories? And do BMI trajectories have a sort of like mediate the association between smoking and COPD with mortality? And so we included almost 3,000 prevalent and incident COPD patients matched to non-COPD patients from 10 practices. And that was from 2005 to 2019. They had to have at least 2 BMI measurements, but we ended up doing an additional analysis where patients had to have at least 3. They had to be 4 or over at diagnosis. And so we ended up having 10 groups total. And so it was never smokers, former smokers, sustained quitters who basically were current smoker at baseline and then quit. And then intermittent smokers were, again, current smokers who were going kind of back and forth from smoking to quitting. And then continued smokers were current smokers at baseline who remained current smokers throughout follow-up. And that was, so that 5 groups were for COPD and non-COPD. And then we modeled BMI measurements over time using mixed effect models once again. And we tested if BMI over time mediated the association between COPD and mortality using time varying Cox regression. And then we also used a user written program called Med4Way from First Data. And so some baseline characteristics, non-COPD patients tended to be older. They were more affluent according to the Townsend quintile, had higher BMI, and more never smokers, fewer current smokers, and they tended to have similar or lower prevalence of comorbidities, except for diabetes, especially where they actually had higher prevalence of diabetes when compared to COPD patients. And so these are the BMI trajectories that we found in patients with at least 2 BMI measurements. And so former smokers tend to have the highest baseline BMI, and that was followed by never smokers. And within these groups, COPD patients tend to have a bit lower BMI, as you can see by the purple triangles and the green the green squares there. And then for all the other groups, they tend to have a much lower BMI. And these are all the patients who are current smokers at baseline, but then had either quit or continuous or intermittent smokers during follow-up. And so they had a lower BMI, and we found that patients who were continuous smokers tended to have an increased rate of decline in BMI over time if they had COPD when compared to those who did not have COPD. And those who quit smoking actually had an increased rate of a gain in BMI if they had COPD when compared to non-COPD quitters. And then patients who were intermittent smokers actually had somewhere in the middle where they had a trajectory that was somewhere in between. However, COPD patients who were intermittent smokers actually had somewhat decreasing trajectory, whereas intermittent smokers without COPD had a bit of an increasing trajectory. And then those with at least, at least 3 BMI measurements, we found similar results. It's just everything seems to be a bit tighter. So there's more overlap between the non-COPD and COPD groups within smoking status groups. And again, we still see that if you're a continuous smoker with COPD, you have an increased rate of decline when compared to a similar group among non-COPD, and that's sort of mirrored if you quit smoking. And then for this, we looked at the association between the smoking and COPD groups with mortality. And on the left, we did not adjust for time-varying BMI. And on the right, we did. And we're looking to see if the effect estimates changed between the left and the right as sort of evidence for mediation by BMI. And we found that the estimates didn't change all that much. Some of the estimates are are a bit wild looking because there's relatively few patients in some of these groups. But we're mostly just looking at the change in the estimates, and we didn't find evidence of really any change in these estimates. And then again, using the Med 4-way program in Stata, we found that the p-value for mediation by BMI was 0.83, so there's no evidence of mediation. And so some limitations, the recording of smoking may be less frequent in non-COPD patients. If they're healthier, then clinicians may not look out for asking them about their smoking status. And so if they quit, that wouldn't have been recorded, and they may have been misclassified as current smokers. But if these non-COPD patients are suffering from other diseases related to smoking, which is a lot of diseases, then that wouldn't have been much of an issue. We did find that non-COPD patients were more likely to have diabetes than COPD patients, but that may be due to our requirements to have at least 2 BMI measurements. And if patients have diabetes, then clinicians may actually measure their BMI, or more likely to measure their BMI than if they have COPD. And BMI may not be clinically relevant as something like muscle wasting, which is found in COPD patients, but we found that BMI is much more likely to be recorded. And again, the low BMI is established as an independent risk factor for mortality in COPD. And so some strengths, as far as we know, this is the first study to look at the impact of smoking in both COPD and non-COPD. So we're able to distinguish smoking status within COPD patients. We had long-term follow-up for BMI measurements. Patients had an adequate number of BMI measurements, and I think the average was around 8. And approximately, we use the mixed effect regression again, and that has its advantages, similar to the last study with missing data. And so our results are consistent with findings from previous studies. So it's been found that there are 2 types of COPD patients, generally speaking. So there's the pink puffer, who tends to have emphysema, and the blue bloater, which tends to have chronic bronchitis, or primarily chronic bronchitis. And so we've known that pink puffers tend to have mostly emphysema, suffer mostly from emphysema. And recent studies have found that patients who who have a prior history of smoking versus other factors like biodiesel exposure or anything else, pollution. Patients with emphysema tend to have a history of smoking. And so this is kind of consistent with our findings that that smoking may be related to decreasing weight over time, which, as you can see in this in the left, the pink puffer is losing weight quite rapidly. And so we found that smoking and COPD may jointly influence BMI over time, and their relationship with prognosis may be causally independent of these weight changes. And so currently we're in a bit of a COPD renaissance where FEV1 is no longer at the center of everything related to research and care in COPD. But the question is that should we go even further? And so gold stage 0 is a type of patient who has normal spirometry. So they have what's considered normal FEV1 obstruction, but they actually suffer from chronic respiratory symptoms. And unfortunately, these patients will not be diagnosed with COPD and receive proper care because their FEV1 is normal, and diagnosis is completely related to whether or not their FEV1 is at a normal ratio to their what's called FVC, forced vital capacity. And so we're kind of studying whether or not chronic respiratory symptoms still have an effect on prognosis, despite the fact that these patients have normal spirometry. And so maybe these patients require some more investigation about their airway disease. And so I guess we go back to the question, can research using real world data lead to improved patient management? And yeah, so as we saw that COPD is a heterogeneous disease, and that there's a bunch of components that may provide additional independent clinically useful information for better management of COPD. And doing this might identify subgroups within COPD. And real world data may allow you to access or to assess non-traditional outcomes such as BMI or other components over an extended follow-up time. Real world data can be used to measure also quality of care in medical practices and to establish best practices and standardized care. And using this data can reflect day-to-day care, which can be used to assess the effect of decisions and treatments in a sort of a non-idealized setting. And real-world data can strengthen clinical decision-making as well by allowing clinicians to be more data-driven and experience-driven. Yeah, as explained earlier, real-world data is generalizable to the population. So any research that's performed can be applied to a broader population. And I want to thank you for listening to the talk, and I wanted to thank my supervisors on the left and also Cegedim. Thank you.
Thank you, Spencer, for your great presentation. So we have seen that the usage, we have seen that the usage of real-world data can lead to improved patient management in COPD, thanks to predictive analysis. Indeed, if we are able to predict the evolution of a disease based on different scores, or if we are able to identify in advance the patient who will respond well to a treatment, we maximize the benefits and limit the risks. What we have seen in COPD can be generalized in all therapeutic areas. Indeed, all therapeutic areas can benefit from improved patient management thanks to real-world data. With the data collection from SIN, we can cover a lot of disease, from rare disease to cardiometabolic disease. Rare diseases are indeed available and can be detected through algorithms. As there are several countries in SIN and a common data model, beyond country specificities, patients with rare disease from all countries can be analyzed together to have a higher sample. Also, many long-term conditions, more or less important in terms of number of patients, can be analyzed in SIN in various therapeutic areas: gastroenterology, dermatology, virology, rheumatology, neurology, respiratory, cardiology, and metabolic. At last, disease more managed in secondary care, such as cancers, for example, can be captured as well, as GPs may report or capture events afterward. Why does real-world data open to a wide range of applications? The value of real-world data lies in the fact that it describes current practice and the effect of a treatment on patients' quality of life, aspects that cannot be captured in clinical trials where patients are selected according to inclusion and exclusion criteria. Thus, real-world data offers infinite possibilities in terms of predictive analysis. Recent advances in artificial intelligence, in particular machine learning and deep learning algorithms, allow the exploitation of this data. By exploring this reservoir of data, the algorithm to identify patterns in order to produce predictions. It allows an expansion into a wide range of applications, which allows us to address several objectives. For example, continuous learning process around the treatment brought to the market. Estimate the probability of success of a treatment on different target populations. Identify unmet needs. Develop specific treatment for subgroups of patients. Provide the authorities with decision support for a better allocation of resources. And enrich clinical trials by contributing additional evidence or adding a synthetic third arm, by helping the design of patient selection, or by validating the feasibility of a protocol upfront. This list of exciting objectives is not exhaustive, but it shows a high potential of real-world data. I hand over now to Gilles, who will conclude.
Thank you, Caroline. Thank you, Spencer. Wow, if I get back to Spencer's presentation, I'm really happy I stopped smoking, watch my weight, and practicing sport. So now to get back to a key question about the value of SIN. This presentation on COPD is a perfect illustration of the contribution of SIN data and what characteristic of SIN should be kept in mind when dealing with such issues. Above all, SIN is robust, and we are very proud as researchers, and once again, thank you so much, Spencer, that researchers are using it in several countries. Of course, this recognition is based on specific characteristics. The first one, due to GDPR, and most important, SIN is anonymized, and also anonymized, but with a long history. Now, SIN, it is around 68 million patients in 5 countries, and more when Italy and Germany will join the common database. SIN is a medical data with diagnosis, lab test results, procedures, patient pathway, and so on. And to work on medical real data is one of the major challenges. The disease coverage is huge, from rare disease to cardiometabolic, and of course, SIN data can be used as a reference with the healthcare authorities. Now it's time for the chat questions. So don't hesitate again to use the Q&A section located in the lower part of your screen. So I think that we can start with I have one question. One question for you, Spencer. What is the future of real-world data, and what next steps can we take to improve clinical practice and care using real-world data? Spencer?
Yeah, sorry, I was muted. I think that the future is in personalized medicine, which I guess going back to the presentation is primarily looking at other multiple components within patients to sort of tailor treatments to a specific patient. And we may be able to generate hypotheses on treatment and decision efficacy if we are able to consider, like, all these other components, not just the ones that I talked about, but other symptom scores and things like that. And especially in a real world setting, I think that part's important as well. And I think also I mentioned a little bit about sort of standardizing healthcare and making sure that that we look at the quality of care across practices and make sure that everyone's on the same page about how to treat different patients. So I think those are the next steps with that real world data can really help with.
Okay, thank you, Spencer. We have another question, and this question is for you, Caroline. I'm just reading the question. SIN data is from hospital and primary care. It's a question. If yes, can you give us an approximative percentage of how many data you have from primary care and how many from hospital? Particularly interested from the Spanish data. And Caroline, I think you can also illustrate the percentage in France, but also to try to answer for the Spanish data. Caroline, up to you.
Yes. Yes. So SIN data is mostly primary care, but we can also collect information from hospital if GPs or physicians are reported information afterwards. In France, thanks to the reimbursement, we can capture hospital data in addition. And in Spain, we have a lot of specialists, and we can collect also information from them, and it represents around 15% of the prescription that we can collect. I hope I could answer the question. If you need more information, we can send you more information after.
Yes, of course, we can give more detail, and we will write more detail for the answer, because we have we have all the question. And the last one is for you, Spencer. Given these important findings for COPD, how do we ensure these learnings are implemented in routine clinical practice?
Well, I think that we're a bit far from implementing these specific findings, just because I think more about the mechanisms. So for instance, the smoking BMI study, I think we need to look more at the underlying mechanisms behind how smoking is decreasing BMI. And I don't think that's actually been shown in even the general population studies that have traditionally looked at these kind of questions more. And Yeah, as for the first part, I think there needs to be a much greater emphasis on using prognostic scores and before actual serial measurement of prognostic scores is considered. And that's not limited to the ADO score. I think other scores we may be able to measure those serially as well. And previous studies have looked at the BODE score and actually looking at the impact of something like pulmonary rehabilitation. And so they use serial ADO scores, so basically just before and after pulmonary rehabilitation to sort of see what the effect of this treatment in particular has on a person's risk. But I think we need to probably emphasize the use of prognostic scores after these impact studies come out, which will be hopefully soon. And then also, we need to also emphasize personalized medicine as well. And I think there's definitely a future for that, and especially in COPD. And then I think the studies that I talked about today can kind of sort of fall under the umbrella of personalized medicine. And so I think it'll all kind of come together sometime in the future.
Okay, thank you, Spencer. So we have also other questions, but we don't have enough time. So we will get back to people who ask questions and to give more details. So we will answer to all the questions, but now it's time to close. So once again, thank you for participating to this webinar. And before to leave, I take the opportunity to inform you that we are going to organize another webinar in collaboration with Reuters, which topic is real-world evidence, novel usage across the pharma value chain. It will be held on April 13 at 3 p.m. CET with some experts from Sanofi, Mr. Ramon Hernandez, and from Johnson, Mr. Nigel Hughes. We will discuss about how real-world evidence is being applied in the whole pharma value chain, like improving trial efficiency with novel design approaches, identifying unmet needs in R&D, enabling outcomes-based pricing agreements, providing real-time insight to HCPs, and also providing more strategic insight to enhance decision-making. So you can register now and see you there in a few weeks. So thank you again, and bye-bye.